Welcome to The View on GU, the place to be for translating uro-oncology knowledge to action. Here are your hosts, Drs. Aly-Khan Lalani and Christopher Wallis.
Hello and welcome to The View on GU. I'm Aly-Khan Lalani, joined by my co-host Chris Wallis. Wrapping up our ESMO 2025 summary podcasts, we invite you to check out our bladder cancer and prostate cancer ones. And now we're going to talk about kidney cancer, near and dear to our heart, Chris. Look, didn't have the thunder of bladder and prostate, and that's hard to beat, those presidentials. But there's always important data, especially because this bar has moved so much with recent first-line advancements that did take the stage at all these presidentials in the past. And then we had adjuvant data previously, lots of controversy there. So why don't we go into kidney and go right back to that space? There's some perioperative data, but probably the big one we wanted to see was the readout from RAMPART.
Yeah, so I think, if we're trying to think about how this meeting advances us, this is an incremental kind of meeting, right? This isn't one of those, groundbreakers, big steps, but this is, I think, incremental knowledge that helps us understand the disease a bit better, plan future trials and plan future interventions better. And that's probably across kidney cancer. So back to the context you laid, which is, the peri-op setting, adjuvant therapy. We've had a real mixed bag here, right? A couple of negative trials. The one trial, Keynote 564, that stands out as a positive trial, positive DFS, positive OS, access, reimbursement. I think it's part of our clinical practice, and we'll talk about that a little bit more. But every time we've seen a talk on adjuvant to date, there's always been, but we will await RAMPART. And we don't have to await RAMPART anymore because the first results were presented by James Larkin here at ESMO 2025. And so to contextualize this is a phase 3 RCT of using adjuvant durvalumab, either as monotherapy or with tremelimumab in resected RCC. This is a slightly complicated trial, to be totally honest. So, we're looking to enrich a surgical cohort for patients who we think are likely to have recurrence events and therefore may benefit from adjuvant therapy. In this context, they're using the Leibovitz scale that's derived from Mayo Clinic.
What do you think about that? What do you like to use?
Yeah, so I think it's totally reasonable. This is there's many ways to skin a cat, and this is one of those situations where I don't think there's a clear best approach here. Some people will use a UISS kind of score. Some people will use the Assure nomogram. I think Leibovitz is very reasonable. Honestly, I find the Assure nomogram very easy to use, easy to access online. Put your patient's parameters in. They'll give you a nice predicted outcome that you can use for counseling your patients. But I think regardless of what tool you're using, the key is that post-resection, post-nephrectomy typically here, although occasionally partial nephrectomies come into this space, you need to be thinking about what's my patient's chance of recurrent disease and might they benefit from adding some adjuvant therapy. And so as long as you're thinking in that context, I think we're headed in the right direction. Here we're thinking about high and intermediate risk of relapse according to a Leibovitz score or fully resected synchronous metastases, and either that could be ipsilateral adrenal or soft tissue as long as it was fully resected. This is a complicated 3:2:2 randomization between active monitoring, a little bit different than a placebo arm, versus durvalumab for a year versus durvalumab with tremelimumab. The durvalumab for a year and only 2 upfront doses of tremelimumab, day 1 and then week 4. So that's a little bit front-end loading that CTLA-4. I think these are, interesting differences we see in terms of study design between trials. And then it makes it a little bit hard to do our head-to-head. We shouldn't be doing it anyway, but it makes it even slightly more complicated. When we move through the consort diagram, in the context of the pairwise comparison we see here, which is between active monitoring and the doublet arm, so the durvalumab plus tremelimumab, we have about 565 patients. Of those, 340 allocated to monitoring, 225 allocated to the combination. That fits with our 3:2 kind of balance. I think if we think about demographics, this is a very reasonable cohort. It's actually a little bit young, I would say. Median age under 60. Relatively high proportion of radical nephrectomy, 85%. That's actually a little bit lower though than some of the other trials. So there's a bit more partial nephrectomy probably happening in this cohort. And importantly, this includes both clear cell and non-clear cell histology. So the other trials have restricted us to clear cell. Here, we don't see data that's going to stratify this out, but I think it's an important step forward, including these non-clear cell patients, because to date, we don't have any adjuvant data on these patients and we don't have any guidance for them. And so I think that is an important characteristic to call out in that sort of background demographics portion of this trial. As we move on to the results, DFS, just like all the other adjuvant trials, is our primary outcome here. And so we're seeing improvements in 3-year DFS from 73% up to 81%. That's a hazard ratio of 0.65. That's a pretty impressive result. And I think really, reinforces the results we're seeing out of 564, where we can improve outcomes for patients with intermediate and high risk resected RCC by adding some adjuvant IO.
But Chris, I thought in Keynote 564, intermediate high risk benefited the most and drove the most. And now you're going to tell us in RAMPART, if you broke it down by intermediate Leibovitch versus high, what did that look like?
Yeah, so this is the interesting part about 564, right? Is that intermediate, high, and M1 NED all benefit with an increasing relative benefit, but a preserved magnitude of benefit in the sort of lower risk end of the inclusion criteria. And here we see really interesting statistically significant interactions between risk group and the magnitude of benefit. And so, the p-value here is 0.019. So this is actually really strong interaction. Nick James in the prostate session told us that anything over 0.1 should be considered meaningful. Here we've got, dramatically more than that. And so we see that in the intermediate risk patient population, no benefit. And in the higher risk subset, a really significant benefit, with the hazard ratio rising from the aggregate of 0.65 all the way up to 0.52. And so, I think that's an interesting difference between these studies. Conceptually, I think it makes sense. The higher risk you are for relapse, the more you are likely to benefit from earlier intervention. It's a reason why these trials didn't enroll PT1As, right? We know that if your baseline event rate is so low, you probably can't benefit. So I think there's some conceptual logic there or intuitive results that come here. But reconciling this with 564 is going to take a bit of work, I think, on our part.
Yeah, and the reason I needed to jump in there is because I'll tell you what I see in clinic right now, and you and I know that we generally allow all of our patients to hear about adjuvant pembro, and in this case, as the only approved agent, and our urologists and uro-oncologists are so good at referring them. But one of the things we struggle with is having a very common PT3A grade 2 or grade 3. Okay, so if I'm interpreting Leibovitch correctly, but PT3A gives you a score of 4, right? Grade 2 gives you 0. So let's say it's PT3A grade 3, which is a score of 5, and that's intermediate risk. You'd need something else like necrosis to get you up to that high risk, Leibovitch, which in RAMPART showed a benefit. But on the basis of being basically PT3A grade 2, we are giving patients adjuvant pembrolizumab based on that trial. So I agree with you that it is nice to have the signal of a trial. I don't know how to reconcile those differences because, it's kidney cancer. I mean, I wouldn't assume patients in UK have, vastly different kidney cancers than in Asia or America or wherever.
Yeah, I think there's key limitations to using Leibovitch, and one of them is that sarcomatoid doesn't show up as a risk factor, and we know that sarcomatoid makes people pretty exquisitely responsive to IO interventions, and in the subgroup analyses coming out of 564, that is an important predictor.
Now that might push the grade though. So Leibovitch does give grade, the so-called grade 4 a score of 3. And so I agree with you that if we had, PT3, sarcomatoid, that immediately becomes high risk. And that kind of fits with what you're saying, especially if you wanted to add TREMI, which I guess is what we should get to, right? Which is, the cost of doing business, which is side effects.
Yeah, absolutely. I mean, the one thing I would just say there is think about the DFS and that higher risk subset. It's really pretty meaningful. At 3 years, we're going from 61 to 78%. We're nearing a 20% DFS difference here, 17% DFS difference at 3 years. That's pretty early on, and it's a pretty big magnitude of benefit. And so just to sort of tie a bow on that high risk question, I really think it emphasizes that we we should be doing something, particularly for that higher risk subset of patients. As we move on to the toxicity, clearly, this doesn't come for free. There's a cost to doing business. The Tremi is front end loaded in this trial, right? 2 doses in the first 4 weeks, and perhaps not surprisingly, you get pretty significant immune-related AEs. Any grade is around 66% of patients getting an immune-related any cause AE, 97% for any grade AE not restricting to the immune-related. And I think Tremi and Durva both share a bit of blame here. We're seeing 79% were attributed to Tremi, 89% attributed to durvalumab. But when you move into the higher grade ones, grade 3 and above, again, 35% Tremi-related, 39% of patients getting a Durva-related event. I think, this just emphasizes there is a cost to doing business, and it will be nice to see the more mature data coming out of RAMPART where we get the Durva mono arm, and we can really see, the additional cost of doing business by adding Tremi, and conversely, what additional benefit we may see from adding that CTLA-4.
Yeah, I mean, a third of patients having an AE leading to treatment discontinuation, patients died. Unfortunately, in these trials, it does happen, but and then, more than a third needed steroids, which could be related to a lifelong toxicity. So, I mean, I'm with you. Like, I think it's nice to have a signal of trial showing some benefit. I think you mentioned this, that it was a big effort, initially over a 1,500 person trial, modified during COVID with this 3:2:2 randomization down to 750. And we'll need to see the single agent Durva data. And at least there's something else in this space, but that reconciliation of which risk group should be getting it, I think needs further follow-up. And it will be interesting to see where all that dust settles, because we want to try and put the pieces together across kidney cancer, because we've seen the other so-called PD-1 CTLA-4 Nivo, IPI or Nivo being, largely negative trials with a control arm, and intervention didn't seem to have much difference. So, yeah.
Yeah, this gets a year of therapy, a little different than the Checkmate trials with 6 months.
Yep.
But, there's those subtle differences between trials that makes it a little bit hard to reconcile what exactly is going on. But I think the clear message, for me at least here, is that in these particularly high-risk subset of resected RCC, these patients have a really meaningful risk of disease recurrence and progression, and we ought to be doing more. Right now, with what's available in our clinics is Pembro, but I think RAMPART offers us further opportunities to envision a near future where we maybe have additional treatment options.
We were talking about this off camera before, but even just the whole surveillance of RCC, we have a lot of guidelines that we're using, or guidance that we're using, that maybe aren't perfectly well balanced for a contemporary era, because even these lower risk RCCs can recur more than 5-10 years later. So that's for another day.
Absolutely. So maybe as we're transitioning out of the adjuvant space, the next obvious place to go is first line metastatic. We saw, we've seen over maybe the last 5 years, real transformations here. We've got a sort of doublet based approach being standard, IO, either with a second IO or IO TKI, but we always want new mechanism of action, new pairings. And from Keymaker U03 substudy 3A, we saw a whole bunch of different combinations we might be interested in first-line metastatic RCC.
Yeah, I think this is kind of setting up for what we hope will be in 2026 big time for kidney cancer in terms of frontline triplet trials, the Merck 6482012 or LIGHTSPARK-12. And so to build upon that, we have this sub-study, which is looking at largely response-driven outcomes for a bunch of combinations. So, we're trying to understand, building on Len-Pembro as a backbone, can we add anti-LAG-3 treatment? Can we add the CTLA-4 component? Can we add belzutifan as HIF-2 alpha? And what about on a backbone of Pembro with belzutifan, can we add a TIGIT-3? The reference for all of these, again, not comparative, is having a Len-Pembro arm. And so this, kind of efficacy endpoint of response in this study had a different lead-in phase and then expanded arms. But I think the big takeaway, especially if we look at response, is that if we start with the reference of len-pembro, we see in this study, again, 62 patients for this arm, but a response rate of nearly 80%, which is really compelling. And quote that as you may, because this is a smaller study and these aren't directly compared. But the len-pembro with anti-LAG-3 had a response of 62%. The len-pembro, when you add the CTLA-4 from Merck, got a response rate of about 71%. A little bit disappointing to see the pembro-bel with the anti-TIGIT getting 43%, but the len-pembro plus bel got a response rate of 77%. And then they quoted a bunch of data in terms of PFS and OS. I always get a little bit worried about quoting that as definitive data because these are small numbers. It wasn't what it was really looking for. But nevertheless, you could get median PFSs for the len-pembro in the 26-month range, which, again, 2 years of being progression-free with a stage 4 kidney cancer is pretty impressive. But getting that up to like 31, 32 months with len-pembro plus bel, I think I interpret this data just to give us this look-see, kind of a sneak preview of what we might want to see in a large randomized phase 3 trial. So just a reminder, that trial looked at len-pembro or the co-formulation of the PD-1 CTLA-4 as well as lenvatinib, or looking at len-pembro-bel. So here, that len-pembro-bel arm was quite interesting, I think, for better or worse, and it's really good to look at LAG-3 and TIGIT and other putative checkpoints that we thought were important, and I think they were right to do. They're probably not moving forward, and reason why they're not in future phase 3 trials. But I think it is setting up the stage for what we hope we'll see in 2026, maybe with LIGHTSPARK-12.
Yeah, absolutely. And I think, we're adding to a TKI and IO backbone here. The question always is, for building doublets and triplets of first line, it opens up the Pandora's box of what do we do in second line. So even this dumb urologist knows that cabozantinib is a very important drug in our sort of backbone of treatment approaches, but we're always trying to do better. So you want to walk us through len-cabo?
Yeah. I mean, this was great work presented by Andy Hahn and led by Nizar Tanir in the group at MD Anderson. So really great work to ask a very pragmatic question. What is it like when we look at these combinations up front? What do we give next? And so Len-Ev, which is FDA approved, Health Canada approved in many countries, but not reimbursed in all of them. Certainly in Canada, it is tougher to get depending on insurance. But nevertheless, there was a registration phase 2 trial of Len-Ev. And so this trial was essentially saying in a phase 2 setting, can we see how Len-Ev, Len at 18, everolimus at 5 daily goes against cabozantinib, randomized 1-to-1, 90-person trial for patients who have clear cell RCC and progressed after immunotherapy, stratified by MDC risk group and prior receipt of VEGF targeted therapy. Again, an interesting study, just I think to look at PFS and can we get a hint of what's going on. This was a multi-center investigator-initiated trial, so again, kudos to the team to pull that off. I mean, what you see is that in all patients that they reported on, 86 patients, 40 in Len-Ev, 46 in cabo, largely well-balanced, although it is important to point out that most treatments had one prior line of treatment. Okay, so 70%-ish of these patients had only one prior line, of whom only about 43% had a prior VEGF targeted therapy. So you could imagine a lot of Nivo-Ipi progression here as a first line option. Maybe they had Sutent after and then this trial or directly this trial. So, we'll get into that in the paper. But I think the real takeaway at this point is in the first kind of signal readout, cabozantinib had a median PFS of about 10 months. Len-Ev looked like, 15.7 months. Hazard ratio was really impressive at 0.5 for the totality of the curve. And what was interesting is that response also looked better. In the Len-Ev arm, 53% primary progressive disease was low in both of these studies, less than 10%. But the odds ratio was about 1.87, so not significantly different. OS was kind of immature at 20 months of median follow-up. Patients in both arms seemed to really overlap with a hazard ratio of 1.05, north of around 85% 1-year OS probability. But again, with how active these drugs can be, especially if you've not had a prior VEGF TKI, I think there certainly needs to be longer follow-up. So, again, my takeaway is this is a tease for what we'd want to see in a future trial. So for example, among many others, there's the LightSpark 11 trial looking at len plus bel versus cabozantinib. And so, we'd like a future in many countries around the world where we can go from doublet to doublet routinely. And it needs to be beat because, as you say, and I consider you a smart urologist, but, cabozantinib is there in Canada and many other countries. Cabo is such a good subsequent line option. I think it's an interesting commentary that in the U.S., I think Nivo-Cabo is at higher use because it was, I think just in the water sooner than some other countries where it came later. So Cabo has been felt to be such a good so-called salvage or subsequent line option. And so I think it will be nice to see where doublets like len-bel or others go against Cabo. So that's kind of where we're at in terms of some of these trials that we're reading out. I mean, lots more that was there, but I think those were really teasers for hopefully kidney cancer to take the front stage in 2026.
Absolutely. It's maybe a setup year for us in kidney cancer. You want to walk through, there was a whole session that I think was a pretty deep dive on biomarkers and maybe walk us through where you see some of this emerging data, giving us hints of what might be clinically relevant soon.
Yeah, I'll make it rapid fire here, just as we come to wrap. But I mean, I think it'd be important to point out, as we've learned in even the atezo-bev data for kidney cancer, remember that combination? We got a lot of good signatures, right? Clusters of where we think patients might be driven by angiogenesis or other immune kind of phenotypes or overlapping. And so the OPTIC RCC trial tried to say, hey, in RNA-seq data, so again, feasibility to even pull that off, can we understand the benefit of Nivo-Cabo in these kind of cluster 1 and 2 from that initial IMvigor data? So I think pulling off that trial was really interesting. It was kind of more done in largely one center for the analysis. So again, I interpret that as saying we're going to see more data of these cluster excluded or clusters that weren't included for Nivo-Cabo. So where does that go? But I think it's an attempt. And I think it's worthy to say, could we use novel RNA-seq coming from atezo-bev, so a different trial? Can we copy-paste that to something more rational and pick based on that? So more than the outcomes I'll get into, I'll just say that I think it's a great foray. But
what do you think about logistics?
Yeah.
So their turnaround times, it was bemoaned a little bit by Dr. Hayek when he was talking about it. Like, I looked at that and I thought the idea of getting, from a diagnosis date through to some tissue acquisition through RNA-seq to something that's clinically actual, he was talking, a couple of weeks.
Yeah.
What do you think in the Canadian context?
Yeah.
Can we do this?
Yeah, just ex-US or maybe just outside of ivory towers that have these capabilities that we have in Canada or other places. Listen, 2-week turnaround to get a patient that might have been recurrent RCC from a nephrectomy years ago, or getting a fresh biopsy now to do RNA sequencing, which is important. I think that's pretty impressive. And again, I think it was largely sent to one institution to do that data. So that's why it's feasible to pull off. I think to scale needs us to come back to first principles, like, are these the right clusters for all treatments? I think it's clear. One thing I took away interested in these biomarkers is it's not surprising a big kidney mass that has a lot of vasculature and is angiogenic has more angiogenic signatures in the primary. And that's the other piece. We've done work on this before, primary and metastatic, so-called staining or sequencing data, but the metastatic sites are important. And then which metastatic site do you pick? If you pick more quiescent endocrine type organs, like what do you expect to see RNA sequencing there versus lung versus liver? So there's a lot about the site you pick, and then of course just getting it done. But listen, kudos to pull that off, because we're just trying to get better at how we refine these treatments and who we're giving them to. I'll just quickly go through some other ones that I thought, great work by many people, so I don't want to exclude. But the biomarker of KIM1 is really exciting. I think Vince Chu out of Dana-Farber has been leading a lot of this, and I think really important to look at the signals across many different trials and say, hey, are we seeing something consistent? So unsurprisingly, we have seen that in kidney cancer, this KIM1 data looks very interesting. It is looking that it may even be able to predict kidney cancer recurring. I think for me, I'm excited about it as an MRD biomarker, but I think also looking in Cosmic 313 to say, at the start of treatment, Cosmic 313 had a Nivo-Ipi arm versus Nivo-Ipi-Cabo. It looked like it was prognostic at baseline, poor risk had higher KIM1, primary in situ had higher KIM1, again, fits with everything. and then perhaps changes seem to correlate well in the Nivo-Ipi arm. But as we've seen, that arm that has the TKI is not quite correlated with time to event outcomes as well. But I think it's just saying we're now starting to get our feet really under us to say, look, Kim1 is there. It's a cheaper test to do. You and I have talked about this. If it's for MRD and people aren't sold on adjuvant for all, why don't we do an MRD-based test to give adjuvant therapy? So we should come back to that. But I think that was nice, and probably more to come as we validate from prior trials in the kind of more mono IO era to now more a contemporary trial. So good work to those folks. I'm interested in the microbiome, gut health. What does it look like in gut microbiome samples? How much does your origin matter? How much does your diet matter? And the question is, can something like MADCAM or soluble MADCAM1, a test in the blood, really nice data presented by the group, led out of Dana-Farber, but also others participated. It looks like it's predicting outcomes in independent clinical trials. Admittedly, axiavelimab is one of the trials, which again is not widely used around the world, and some other historic trials. But again, you got to start somewhere. It looks like it's prognostic. I'm not certain the data of, high to high looked good, right? Low to low looked bad. That going from low to high or high to low, I think it still remains to be seen which of those matters. But hey, if there's a blood test that can tell you about what it looks like from a microbiome perspective, as mucosal cells kind of give us signals in our body that we can test in the blood, I think that's kind of interesting. And so, follow the space, because we have been looking for eureka answers and we don't have them quite yet. So I think that was quite interesting. And then again, lots of more data. Look, gallium-68 PET scanning in kidney cancer. I think the CA9 or carbonic anhydrase 9 will be very interesting when we look at some of the TLIX works that's coming. So look, potpourri all over the place, but really nice work being done. So kudos to everyone, because we're trying to advance blood work in kidney cancer.
Mm-hmm. Yeah, I think, if we put it all together, ESMO 2025, maybe a bit of a setup in kidney cancer for some really big things to come, both in terms of, biomarkers, disease monitoring, but also set up for novel treatments. So we saw, earlier phase data that really line us up for some, hopefully, 2026 readouts of big phase 3s.
Yeah, absolutely. I think more to come. Really exciting for what we've been able to pull off so far in Berlin. I hope our listeners and viewers enjoy listening to all of our podcasts, including Kidney. Chris, any plans for the rest of Berlin?
Yeah, my wife just joined me, so we've got a nice tour of the city. Hopefully the weather holds up for us. I know you're off to Jordan.
Yeah, not in Germany, but gonna check out Jordan. Just a quick hop over from Germany, right? So that'll be interesting. It's always nice to meet up with some of our colleagues. So thank you to our listeners and viewers. It's amazing how many people internationally kind of said, hey, I'm checking out your podcast, or excited to listen to the rest. So as always, like, review, subscribe. We're always keen to hear what folks want to hear. But on behalf of Chris, I'm Aly-Khan. Thank you for listening, and we'll join you shortly.